Yeah. Yes. Now we are recording. Okay. Yes. Good evening, doctors. Welcome to All on 4 webinar. Let me share the screen so that you can see my presentation. Okay. So just one of you just say if you can say yes if you can see my presentation. One of you just say yes. Okay. Okay. Good. 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 Okay. I think there's a lag in your response, so I should wait for your response. Okay, that's great. Let's proceed now. Just a brief introduction about myself. I am Dr. Akash Chakravarti. I'm an oral and maxillofacial surgeon. I have uh, uh, I have graduated from my oral and maxillofacial surgery from Savita in 2017. I am the managing director of Sarita Dental Clinic in Hyderabad right now. It is a 36-year-old dental practice, and I mainly focus on implantology. I practice only exclusive implant practice. Okay. So we also have our own CAD/CAM laboratory to support our implant work. So we are an end-to-end solution over here. We are a team of 4 people now for implantology department. We have me and we have one prosthodontist, Dr. Sulagna, and we have 2 periodontists, Dr. Gayashri and Dr. Ramya right now. So this is my small team, and this is a brief introduction about myself. So let's dive into the topic right now. Okay, before I start the presentation, let me tell you that if you have any questions, please write them down and save them for the end of the session. I will give you, there will be 15 minutes to half an hour session on question and answer, Q&A. So after the session, I will answer all of your questions. Okay. If I ask you any question in between, just use the chat box and give the answer in that chat box. Okay. So implantology as we know it right now. So when I look at this, a picture like this reminds me of what we have been taught about implants in our textbooks and colleges. The bridge pillar signifies, the pillars of the bridge signifies our implants, and the top of the pillars, the bridge signifies our prostheses, and the river bed in which the pillars are put in, it signifies our mushy maxilla bone, which is very soft. And the forces, the lorries and the transport vehicles on the bridge, they represent the occlusal forces on the bridge. So I feel this is how we were taught about implants. Our implants needs to be straight. Our bridge needs to, we need to place as many as implants as possible, and they have to be straight, and there's supposed to be a prosthesis on the top of it. Right. So even I used to practice that sort of implantology before. I used to place my implants straight, 6 implants in the top and 6 implants in the bottom, and wait for 6 months for osseointegration, and then reopen them again, and do my prosthetic procedures like this. And after about 1 month or so after the prosthetic procedures have begun, this is how I used to give a hybrid acrylic prosthesis. And if you can notice in the pictures, the prosthesis is segmented. It is not a one prosthesis. It is not a full prosthesis. So a lot of I mean, I used to struggle a lot with these sort of implant level screw retained prostheses. I wanted to do screw retained, but it was very difficult to do screw retained implant level prostheses. So if you just back up for a moment, I really feel how I really don't understand how we used to work before. We used to place implants and expect the patient to be edentulous for 6 months. going to offices. These days, patients are very demanding. They want to go back to their work the very next day after their implant surgery. They don't want to wait for the prostheses. That is because the age in which the patients are getting their implant treatment done is coming down and down. We have younger and younger patients who need full arch fixed prostheses, So the demands are much more higher in terms of aesthetics, in terms of phonetics, in terms of the speed in which they get their fixed teeth. Okay. So this was troubling us. This is some of the other cases I used to do before. So imagine a case comes like this. This had come to us, and what can be done in this case, maybe 20 years ago or 30 years ago. Okay, so what would have been done? Okay, so the possibilities are 20 years ago, we have to do a bilateral sinus lifts and extensive grafting. We have to place the grafts. We have to wait for about 6 to 8 months for the grafts to form bone, and then place our implants in the newly formed bone, and then wait for another 3 months or 3 to 6 months for the osseointegration to happen, and then place our prosthesis on the top of the implants. Now, obviously, it doesn't sound too practical these days. We do not have the patience levels of the patients are very, very low these days. So we do not, we do not come across, even if we want to do it, I personally had given this treatment option to many patients, but they have not taken up to it. They would rather go for a removable complete denture rather than go through all of these procedures. Okay, so how it started, my all-on-4 journey, I first learned my all-on-4 journey, all-on-4 technique with Dr. Gunashilan, Dr. Gunashilan from Chennai. So I had my, I think, 4-day or 5-day workshop with Dr. Gunashilan, and I asked him personally to be able to perform a case under him. So I performed a case under him, and that was a great experience for me. And since then, there was no turning back. Once I started doing all-on-4 and I started doing immediate loading in my practice, we have never done any full mouth, full arch implant case where I have not done an immediate loading in our practice. Very rarely we have not done immediate loading in our practice when it comes to full arch. It was always full immediate loading for us. Then after that, I had gone to Dr. Paulo Malo in Lisbon. Okay, so I had gone to him directly, the inventor of all-on-4. So I had trained under him for about 10 days. So to learn in detail about all-on-4 and zygomatic implants. So that's how our journey has started in all-on-4. But when I talk about all-on-4, it's a whole philosophy, guys. It is not just 4 implants and tilting the implants in a way and rehabilitating the patients. The principles and concepts you learn in all-on-4 can be applied to all of the other implantology modalities, any full arch case, any full arch. It is not only about all-on-4. Even if I'm doing 6 implants, I am following the principles of all-on-4. Even if I'm doing 5 implants, I am following the principles of all-on-4. Okay. So the same case, we managed it this way. By then I had understood how to tilt the implants and what to do with tilted implants. And that's how we were able to place the implants in this patient without the use of grafts. And this is how the patient had come to us. And that was her immediately loaded temporary prostheses. And this is her permanently loaded prostheses. Okay. So that was the FP1 processes. That's an FP1 processes. Back then I used to do FP1 processes, but now it is all FP3 prostheses. So you will understand it in the later slides. So let's dive into the topic now. Okay, what is all-on-4? All-on-4 is a technique put forward by Dr. Paulo Malo in 1993 when the first all-on-4 standard was done. It's basically placement of 4 implants four implants placed for in full arch reconstructions. Uh, the angulation can be maximum 45 degrees for the posterior implants. And most importantly, all the implants should have bicortical anchorage. Okay, a lot of people I see on Facebook and WhatsApp and Instagram, they keep posting pictures of saying it is all on four, placing four implants and calling it all on four. uh, it's not all on four unless and until you engage the bicortical. I mean, you engage the second cortex. You have to engage the second cortex. Otherwise, it is not all on four. Okay, so what else is a part of all on four? Use of cantilever if needed, immediate loading with fixed acrylic bridge. Now, the whole concept of all on, I mean, the whole before Paulo Malo had come along and suggested the idea of immediate loading, denture conversion. The whole world was not at all doing immediate loading or denture conversion. We were all waiting for 3 to 6 months for our implants to be able to take prostheses. But that denture conversion and that immediate loading was game changer. And that's how a lot of patients were drawn into the concept of fixed prostheses in the first place. I mean, personally, in our practice, immediate loading had taken our practice, implant practice, to a whole new level in terms of patient compliance. So, and another concept in all on four is bone reduction if needed. All of these things I will be explaining in the slides which are to come yet. So just understand, just keep these points in mind, and I will be explaining, just know that I'll be explaining about all of this in the coming slides. So it enables us to bypass the sinus and attain maximum BIC, that is bone to implant contact, giving us greater primary stability. Okay, so I think this sums up the entire thing about all on four. It enables us to bypass the sinus. If I want to place the implant in that region, I have to do a sinus lift and a bone graft. Because I want to avoid it, I am bypassing the sinus and attaining maximum in order to attain maximum BIC. Okay, and also give us greater primary stability. Okay, so why do we do all on four? Primarily, yes, to avoid bone graft. It is a graftless procedure. Now, when I say graftless procedure, I am not saying I don't use grafts at all in my implant practice. I do use grafts in all on fours or in full arch procedures. It is just that I am not waiting for those grafts to become bone and then load my prostheses. So I will place the implants. If there's any dehiscence or if there's any implant exposure or if there's any deficiency of bone, I will use grafts, but these grafts are not for bone augmentation and waiting for the bone to form or waiting for the bone to form for doing our immediate loading process. So they have equal success rate to axial implants. Now we have evidence to prove it, enough evidence to prove that tilted implants have equal success rate to axial implants. They have a higher capability to maintain hygiene. Now, when you use tilted implants, you have the only option of prosthesis is a screw retained prosthesis, and a screw retained prosthesis with multi-unit abutments is a very, very easy to maintain prosthesis type. It allows the patients to have immediate teeth. Now, as I said before, that the concepts of all on four are more towards giving patients a fixed teeth. It is not just, placing four implants. It is not just, avoiding sinus. It is not just using avoiding bone graft. It is how do you place implants so that you can give immediate teeth to your patients. It increases success rate in patients with diabetes, because these implants, you use longer implants and you're placing your implants in the cortical bone and in the basal bone. These bones are less affected by diabetes, resorption related to diabetes. So that is the reason why the success rate is a little bit higher in the case of, with all on fours in diabetes. Now, I really don't want to go into detail into scientific evidence for all on four. Now, by this point, there's enough scientific evidence out there. to prove that this procedure is a good procedure and we can use this procedure on a day-to-day basis. Let me go through one important study. It's a longitudinal study of up to 10 years of follow-up. So total number of patients used were 245. Total number of implants that were placed was 980. The follow-up was for 10 years. So we have a mean loss of bone of about 1.69 mm. We have a cumulative success rate at 5 years at 98.1%. We have a cumulative success rate at 10 years of 94.8%. And the prosthesis survival rate at 10 years was 99.2%. Now that was in manual, and now this is a study in maxilla. Okay, so all-on 4 immediate function concept in completely edentulous maxilla. This is a 5 years study. So the total number of cases was 242. The total number of implants studied was 968. The total number of failures recorded was 19. So the success rate at 5 years is 98%. Success rate of 5 years prosthesis is 100%. Marginal bone loss at 3 years is 1.52 millimeters, and marginal bone loss at 5 years is 1.95 millimeters. I say that is a very good scenario. Now, the common reservations of all-on-4 concept. When I talk about all-on-4, a lot of doctors have these few common reservations. I thought I would address few of them. Whenever I say all-on-4, this is what comes into, these are the questions that a lot of people ask. What about cantilever? Tilted implants. A lot of doctors are not comfortable with tilting their implants. Immediate loading, again, a concept which is fairly new and difficult to understand. The use of multi-unit abutments. If you're tilting your implants, it is always better to use there is no other option. We have to use multi-unit abutments, and a lot of clinicians are not comfortable with using multi-unit abutments due to various reasons. Either they're not familiar with it, or they think it needs additional equipment, or it needs additional inventory. But I see a certain lethargy in the adaptation of multi-unit abutments. Then prostheses. What kind of prostheses? How do we rehabilitate all-on-4 prosthetically? What are the materials available, and etc. So in this seminar, in this webinar, I would be covering most of these topics in a brief manner, in an introductory form. Okay. So most important thing for all-on-4 or any other treatment modality when it comes to that is treatment planning. Okay, a very good treatment planning will lead to success of a case. If you do not plan for a case, you are in fact planning to failure. Okay, so when it comes to all-on-4, there are two aspects in treatment planning. There is prosthetic planning and there is surgical planning. Okay, when it comes to prosthetic planning, or I would like to say implantology in general, the treatment planning has to start prosthetically. Okay, now you always should begin with the end in mind. So you need to figure out how much space is there for your prostheses, or do you have to, is there an adequate space for your prosthesis, or do you have to create space for your prostheses by the means of bone reduction? Or where do you have to place implants so that the screw holes are not coming out in an unfavorable way in your prosthesis? So your implant positions are always determined by your final outcome of the prosthesis. It is not because wherever bone is available, if an implant is supposed to be placed in a certain orientation for the prosthetic favorable prosthetic outcome, it has to be placed in that way. If there is no bone, we have to go for augmentation with bone grafts in that region. There is no turnaround around prostheses. If prosthetics determine surgery of an implant, it is not the other way around. So if any of you who is listening to this are in a habit of placing the implants first and then calling your prosthodontist later after 6 months for the final, and then asking them, please figure out what to do. It should not be that case. Your prosthodontist should be involved in the beginning, and then according to their planning, you need to plan your surgical placement, so that you need to set up your prosthodontist for success. Okay, while you're placing implants, that should be your primary goal. Because trust me when I tell you, the patients are not coming to you for implants, they're coming to you for teeth. Okay. So rationale for bone reduction. Whenever I talk about bone reduction, or whenever I give out cases about bone reduction, a lot of doctors ask me, why do you want to reduce the bone? Bone reduction is not a good thing. When you have this much bone, why do you want to reduce it? Okay, we all struggle for bone, but then you are taking a burden, you're reducing it. What is the rationale behind it? So first of all, one of the very important, rationale for bone reduction is to hide the transition zone. So when you have a very high smile line like this, and when that all comes in the part of case assessment and patient assessment before the planning. So you ask the patient to smile, and if the patient is smiling too high, and if you feel that the transition zone of the processes in the gingiva is exposed when the patient is smiling, you have no choice. You have to reduce the bone and bring the transition zone above the smile line. Okay. Nobody wants a prosthesis. Nobody wants a prosthesis where when they're smiling, they can see the line between the gingiva and the gums. The gingiva and the prosthesis. Okay, so the next point is to clear out the infectious bone. Now, a lot of patients come to you when their teeth are all mobile and they're shaking. That means there's a lot of periodontitis and infection in their bone with granulation tissue. So you need to clear all of that out, because if you don't clear that bone out and you place your implants basing that as your base, that as your base level, then you are going to be surprised that the bone is going to resolve, because it is an infectious bone. It's not going to stay for long. It is going to resolve. Okay. You take out the alveolar bone, which is prone for resorption. Again, another important point, the alveolar bone, which is housing your teeth. If you do not take it out and you place your implant in that alveolar bone and basal bone, your alveolar bone is going to resorb. You're going to have a higher resorption rate in your alveolar bone. So it is better to remove all of that alveolar bone, get to the basal bed bone, and then place your implants in the basal bone, so that you have a predictable bone reduction, predictable level of bone loss after you place your implants, maybe 5 years, 10 years down the line. To create an even surface for implants for better force distribution. Now, if you have a patient who has periodontitis and he has uneven bone surface, and you just remove the teeth and place implants, you're going to end up in placing implants in different levels. So this is going to create unequal forces amongst your implants and going to create unequal bone loss around your implants. So leads to failure of 1 or 2 implants. Okay, so it is better to remove that part of the bone and create an even surface to better distribute the forces on all the implants equally. To create adequate space for hygienic prostheses. Now, Mallow frameworks, FP3 frameworks are much more better to maintain hygiene than FP1 type of frameworks. Now, FP1 type of frameworks are the frameworks where you only have teeth. Whenever the patient smiles, you can see the teeth and the gum line. That is not good, because the patient will not be able to maintain hygiene over there. If the transition zone is taken up like this and you have a very good FP3 prostheses, you can give nice gap between the gums and the prostheses, where the patient can use a water floss and maintain the prostheses. Surgical planning. Okay, so just give me 2 minutes, guys. I'm just going to drink water. Hey, let's start with the surgical planning now. All I told you was about prosthetic planning. Now, there are a few key aspects in surgical planning. Space. in order to create adequate interarch space, how much bone to trim to create the required interarch space. Now, who will tell you what is the required interarch space? If you're a prosthodontist, you will know what is the required interarch space for different types of prostheses. If you're not a prosthodontist, ask your prosthodontist to come and tell before the case starts what is the required interarch space. If you have the required interarch space, then go ahead. If you don't have, then you need to create it by bone reduction. Spread. Will I be able to place my implants with an adequate AP spread? Okay, to support the prosthesis. The greater the AP spread, that is the anterior posterior spread. What is AP spread? AP spread is the distance between the anterior most implants and the posterior most implants. Okay, the greater this distance, the greater your cantilever can go. The greater this distance, the bigger the prosthesis can come. Okay, so you need to be able to figure out whether this is possible for you or not, or go for other modalities like zygomatic implants or pterygoid implants if all-on-4 is not possible. Okay, stability. Can you give enough primary stability for these dental implants with the availability of the bone and the density and the quality of the bone and the available height of the bone? So you need to be able to plan in terms of whether your implant system you're using has the adequate heights to be able to engage the entire bone and engage the other cortex in order to get the required primary stability or not. Okay, so this is about AP spread, the distance between the anterior most implant and the posterior most implant. The goal is to reduce the cantilever, and the more the AP spread, the more cantilever we can go backwards. Okay, so this is the Bedrosian classification. I think everyone is familiar with it. Whenever the maxillary bone is divided into 3 zones, zone 1, zone 2, and zone 3. Now, zone 1 is between the canines, zone 2 is the 2 premolars, and zone 3 is the molars. So when you have bone in zone 1, 2, and 3, that is when you can go for 6 straight implants. That's a ideal setup, ideal bone. Very rarely I get access to such bones where there is bone in all the 3 zones. In Indian bone conditions, it is very, very difficult to see a maxillary bone with all the 3 zones. If I get such a bone, I'm really happy, and I actually give discount to that patient because it's, I'm happy about that bone situation. So when you have bone in the zone 1 and 2 and no bone in the zone 3, that is when you go for all-on-4, because you want to place your implants in the zone 2. But in order to place a high, long enough implant and a very good enough implant, you need to place it in the sinus, which needs, sinus elevation and bone grafting. So you tilt your implant, you avoid the sinus. So that is the idea of all-on-4. Okay, so any implantologist should be familiar with this graph. It is an implant stability graph. So you see when you place the implant in the beginning, you get a stability that is called primary stability. And after 3 months or 6 months, when the implant has also integrated, that is called secondary stability. Okay, so this graph shows us that the green line shows the primary stability. When you place the implant, it is high, but gradually it dips down, and the secondary stability is the blue dotted line. It is 0 in the beginning, but then it rises up as the time passes. About 7 to 8 weeks, your secondary stability is at the peak. Now, during this in between phase where the primary stability dips and the secondary stability comes up, there is a stability dip. Okay, now this stability dip is very, very important. This, you cannot touch the implant in this stability dip region. You have to let it be. It is a remodeling phase. If you touch your implant in this stage, then you're looking at a failure of an implant. Okay. So different ways to achieve primary stability, different ways to achieve secondary stability. So primary stability can be achieved with osteofixation and osseodensification. So secondary stability can be achieved with osseointegration. Okay, so I am going to explain you about what is osteofixation. Now, osteofixation means it is, as the name suggests, it is where you fix your implants in the cortical bone. Okay, so you see in the maxilla, I don't know if you're able to see my cursor or not. Let me do this. I think now you can see my cursor, right? So this, in the maxilla, this is your second cortical bone. This is your first cortical bone. Okay. So when you place your implant, you need to engage this cortical bone and this cortical bone. Same way, this cortical bone and this cortical bone. Here you start here, you engage the implant in this cortical bone and you place in this cortical bone. So when you engage this part of the cortex, that is called osteofixation, and that is called bicortical anchorage. When you do bicortical anchorage, you are fixating the implant. Now, this is a mechanical fixation. This is not a biological fixation. The implant is held in place by the two cortices during the remodeling phase. That is the reason why you're able to let go. You're able to load it immediately, and then the patient is able to go through the remodeling phase without any damage to the implants or the prostheses, because the implant is held in place with the bicortical fixation during the remodeling phase. If you do not do bicortical fixation, you cannot do immediate loading, because the implant is going to fail in the remodeling phase. Okay, because it is not held together in position by bicortical anchorage. Okay, similarly in the mandible, this is your superior cortex and this is your inferior cortex. You need to engage both of them. If you cannot engage it, sometimes it is too long, you have to engage the buccal cortex. Okay, you engage the lingual cortex and buccal cortex. You have to angulate your implant in such a way that you engage any two cortices. Okay. Now, the second way to achieve primary stability is through osteodensification. Now, there are few burrs like this called densa burrs. You can use these burrs to make a D3 bone into a D2 bone, or a D4 bone into a D3 bone. It improves your stability a little bit much. You do not have to use, if you don't have access to densa burrs, you can also always use osteo. There are these these bone expanders. Okay, you can use these bone expanders, which are done manually with the help of mallet. They also help you in osteodensification. Okay. And the last one is osseointegration. When you say secondary stability, that is achieved by osseointegration. Now, everyone knows about osseointegration. It is the contact between bone and the implant. It is a permanent bond, unless and until there is peri-implantitis or anything else, which is not designed by the implant to take forward, like unnatural forces or something like that. This bond is not going to break. Okay. Okay, let's talk about immediate loading now. Science behind immediate loading. So have a good AP spread. If you don't have a good AP spread, you are going to be giving a short arch, which is not good for the patient. So have a good AP spread. The minimum torque of 35 NCM on all implants and bicortical anchorage. Okay, it is not just enough if you get 35 NCM torque, you should also achieve bicortical anchorage on your implants. Cross-arch stabilization with screw-retained acrylic prostheses. So when you're doing your immediate loading, it is very important to do cross-arch stabilization with screw-retained acrylic prostheses. So why cross-arch stabilization? You're basically taking advantage of combined stability of all the implants, so that you have higher success rate. So make sure you have no interferences in the lateral excursion. Whenever we fix a crown or we fix a prosthesis, we only ask the patient to bite like this. Okay, so that doesn't take care of the lateral excursion. The patient, while he's eating, you will ask the patient will be moving the jaw from side to side, where if the lateral cusps are coming in contact with each other, then that is causing force to the implants. So you need to make sure that there is no lateral excursions. Okay, the contact from canine to canine, which is opposite to the full mouth rehabilitations. Now, whenever you're doing your FMR, your full mouth rehabilitations, you want the contact to be from posteriors until the canines and no contact from canines to the anteriors, right? So this is reverse for immediate loading. If you want to do immediate loading, you have to give contact from canine to canine and do not give contact in the posteriors. This is because the anterior bone is much more stronger than your posterior bone. Your posterior bone is weaker. So you have to get the osseointegration done. You have to wait for secondary stability for you to give contact in the posteriors. And when you're doing immediate loading, there has to be no cantilevers in your temporary prostheses. Okay, so if you want to do immediate loading, you do not give cantilever wherever your implant ends. If it is a short arch, you have to give a short arch. You cannot give cantilevers in immediate loading. So factors determining immediate loading, the number of implants placed. So more the implants placed, better it is for immediate loading. Design of the implants. Active implants are better for immediate loading than passive implants. Active implants will engage the bone and get higher BIC and get higher primary stability than passive implants. Okay, primary stability of the implants. Now that the higher the primary stability of the implants, it is better for immediate loading, obviously. Nature of the immediate prostheses, do not go for permanent materials like metal frameworks or zirconium or ceramic layering suprastructures. Go for acrylic suprastructures, which are very good for force absorption and force distribution and preserve your implants. It might break your prostheses, but it is okay to break your prostheses than having the force transmitted to your implants. Okay, always ensure, always look at your opposite arch occlusion before you do immediate loading. Just judge if it is an opposite arch with already osseointegrated full implants with ceramic prosthesis or a metal prosthesis. Be very careful about it. Do not advise immediate loading, or if it is a screw retained opposite arch, just remove it and go for acrylic on both the sides, both the upper and lower. If it's natural teeth and if it is compromised natural teeth, that is okay. But if it's root canal treated and an FMR with ceramic porcelain teeth all over, then it could be a difficult proposition. Then you have to be very careful about your occlusion. You have to be very careful about your force distribution, and you have to be using a very shock absorbing material. Okay, so next comes cantilever. So unlike the common thought process, it is not, the tilting of, at the act of tilting of an implant reduces the cantilever. It doesn't increase the cantilever. So a lot of people associate cantilever with all on four. No, all on four actually is trying to reduce the cantilever. So if you see in this image, in the second image, where if I'm placing two straight implants, the cantilever is much more higher, rather than if I'm placing a tilted implant, the cantilever is much more lesser. So the goal is always to reduce the cantilever, but a tilted implant is much more capable of taking a cantilever. I will be explaining it to you in the future slides. So a general calculation for cantilever is it is you can go 1.5 times to the AP spread. So whatever your AP spread is, you can go back to 1.5 times to the AP spread. So that is the reason why AP spread is much more important. I usually don't go so back. I usually give one tooth cantilever, which is 10 millimeters, which is quite good. I do not give 2 molars cantilever. It's only 1 molar cantilever. So next point is tilting of an implant. Now, a lot of people think tilting of an implant is only two-dimensional. That is, there is only a mesiodistal tilt. It is not just two-dimensional, it's a three-dimensional tilt. Okay. Let me get my cursor over here. Okay, now I think you can see my cursor too. So Now, why do we tilt our implants? If the implant, if I want to place my implant in this region, if I want my implant to end in this region, I have to place it straight over here. Obviously, I cannot place the implant straight over here because I need bone in that region. So I tilt my implant. Now, when I tilt my implant, notice I've engaged the cortical plate, the other cortical plate. Okay. And if you also see in this particular case, you see root canal treatments done for all the lowers. It's because the lower arch was, because of the supra eruptions, uneven supra eruptions, there was uneven occlusion level. So I wanted an even occlusion level. So I advised for root canal treatments and FMR in the lower arch as well. So just observe this video carefully. This is when I say the tilt of an implant is not just mesiodistal, it is a three-dimensional tilt. There is a buccolingual component. There's a palato-buccal component to the tilt as well. So if you see, the implant is starting palatally, but then it is ending up buccally. So you see, it is the tip of the implant is engaging the cortical plate over there. By doing this extra tilt in the palato-buccal orientation, you are gaining 1 or 2 more of length of the bone. That is more BIC, and then you are able to engage the very good cortical plate. So if you look at a case like this in two-dimensional OPG, it looks pretty simple. It looks that the implants have been tilted, but then the same case, just observe the video over here. The same case, if I show you a three-dimensional view of the same case, let me remove all of the bone and see how dynamically the implants are tilted. It is not just mesiodistal tilting. It is, it's a three-dimensional tilt. See how robust the system appears to be. Now, this is a system in which the forces this system can take up forces from any direction, forces coming from various directions. There is an implant which is taking it up in a longitudinal way. Okay, now this picture depicts why a tilted implant takes up, cantilever forces better. So let me get my cursor back. Now you see there's a tilted implant over here and you have a prosthesis and a cantilever over here. Now, when you give force on the cantilever prosthesis in this direction, when you give stress over here, the strain will be in this direction, right? So if you just extend the arc of the strain, it goes in this direction, in this direction. Now, if you notice that this direction is in the longitudinal axis of the implant, and this is the reason why a tilted implant at 45 degrees, at the max 45 degrees, is good for tilting your implant. If you go beyond that angulation, it is not good for the force distribution of your implants. Okay. Now, let's get into multi-unit abutments. Multi-unit abutments are really, really important if you want to tilt your implants. Multi-unit abutments are the ones which take a tilted implant, and when you look at the prosthetic aspect, it looks straight. Okay, it takes a tilted implant and makes it straight for the easy prostheses and for the prosthetic axis. Okay. Now, this is a picture of multi-unit abutments of a patient after 6 months of the implant. After the implant placement, she had a temporary prosthesis. So when we were taking it out and making a permanent prosthesis, we had taken this picture. Now look at this image. You can see a nice pink mucosa around the implants, nice good seal around the implants. You have seen that the patient is able to maintain it very nicely. The mucosa is healthy. If mucosa is healthy and if it has a very good seal, there is a very less chance of peri-implantitis, and the bone levels are retained. This is the upper. So quick points about why multi-unit abutment is important. It facilitates hygiene, decreases crustal bone loss with better mucosal integration. Now, because you have a multi-unit abutment on which you're interacting with when you're doing the prostheses, you're not interacting directly to the implant, because if you're interacting directly to the implant at the implant level prostheses, you're disturbing you're disturbing the gingiva around the implants each time you want to engage with the implant. Okay, this irritates the gums and they recede back, which creates space for the bacteria and saliva and other things to enter and cause peri-implantitis and cause crustal bone loss. Okay, so having multi-unit abutments will create that seal, and you're only talking to the multi-unit abutment. You won't see the implant ever again in your life after placement of the multi-unit abutment, which is great. Okay, it enables for screw retained prostheses. As I said, screw retained prostheses is much more better than cement retained prostheses. Every 6 months, we can remove the prostheses, do our maintenance works, and place the prostheses back. If the patient has any chip or breakage of the prostheses, we can easily remove it and then repair it and put it back, which is not possible in the cement retained prostheses. Okay. The last point is it facilitates prosthetic procedures. As I said, implant level which is easier, working at an implant level or working at a multi-unit level? Okay, working at an implant level, it is very difficult to get a passively fitting prosthesis. That is the reason why we have to split the prostheses in different regions in order to place the prostheses. And sometimes you won't even be able to engage all the screws. We will leave one implant without a screw in implant level prostheses. That is not the case in multi-unit level prostheses. It is very easy to get a passively fitting prostheses when you're using multi-unit abutments. Okay. So now let's dive into the surgical protocol for all-on-4. Let me show you one case of all-on-4. This is a case I have done as a consultant doctor in one of the interior parts of Telangana. We had gone in the morning. We had placed we had placed all the 8 implants, upper and lower, and we had given a complete, we had given a fixed prosthesis also to the patient. We converted the denture and given the fixed prosthesis to the patient. I think this sums up the entirety of all-on-4. So let me show you the case. This was the OPG shared to me. Okay, this is the intraoral image. This is the upper arch. This is the lower arch. Okay, so this is the incision I had given for the upper arch, and we take a full thickness flap for the upper arch. Now, if you notice, after I have taken the full thickness flap, you see the thickness of the bone, it is very less. That is why I wanted to show you this case. If you have a very adequate, good bone, that's great. But if you have very less bone like this, in these situations also, all-on-4 is good. Except you have to practice few bone modification processes to achieve primary stability in these cases. Okay, so I used a bone ronger to take out some of the alveolar bone. As I previously discussed, you want to remove all of the alveolar bone and make it into a flat surface like this. Now, after bone reduction, you see I've gotten a little bit of width of the bone now, and also you see a flat surface. If you notice over here, the bone is up and down. And now we have a flat surface to place our implants in. So this is a Mallow guide. It has markings like this. It enables us to angulate our implants and also distribute our implants symmetrically. So that is the first implant placed on the first quadrant. And when I tilt the implant to be able to place the multi-unit abutment, I use a bone mill like this. It just removes the bone just enough to house our multi-unit abutment. So this is the other side. Similarly, we had placed the multi-unit abutment also there, and this is the anterior implant being placed. And this is all the 4 implants placed in the upper jaw, and we have multi-unit abutments also placed. Uh, okay, now this is after the closure is done. I use rapid Vicryl, which resorbs in 10 days. I use simple interrupted sutures to close the surgical incision, and healing caps have been placed. Now this is the incision given for the lower, full thickness flap elevated. You can see the how thin the bone is in the lower arch. I have taken my burr to reduce the bone, do my bone reduction. After my bone reduction, you see little bit of thickness of the bone. And this is my mallow guide being placed. And if you notice, there are these pencil marks over here. This pencil marks over here. So what I do is I elevate until I see the okay, there's a question now. However, I advise you to ask the questions later. So there's a question from Dr. Dinesh, how to keep it safe without touching the sinus when we place free hand in these cases. It's a very good question. I wanted to actually tell you this after this thing. So if you see in the first in the first picture, I had placed the implant over here. At this stage, what I do is I take my first drill and I take a IOPA. Okay, I place my first drill and take an IOPA. Now that tells me where I am to the sinus and if I want to change the position or not. The first drill I mean is the the first sharp drill. I don't go all the way in, just 4 or 5 mm, just to be able to place the implant. Yeah, that's the pilot drill. Sorry, pilot drill. Okay, for mandible, what I do is I I open up until I see the mental nerve, and I take a pencil and I mark the pencil point over here, so that every time I don't want to check the mental foramen. So this is the first implant being placed in 30-degree angulation. Okay, this is the second implant. So that is the bone mill I use to remove the excess bone around the implant to be able to place my multi-unit abutments. So this is all the 4 implants and multi-unit abutments placed. And this is closure done with healing caps placed. Now this is the upper arch with converted denture. You notice the implant positions. We have good AP spread and good occlusal placement of implants. And this is the lower arch converted. Okay, this is upper and lower converted prostheses. And this is a final OPG of the case. Now, if you clearly see over here, all the implants have bicortical engagements. Okay. Even in the mandible, I have engaged the second cortex. So that's the patient just after the surgery and implant conversion. So another user has asked how many days we have to wait for temporaries. As I'm telling now, this patient has got her temporary the same day after the implant placement, just after the implant placement. So if your implant surgery is right and you have got a good primary stability, you can go ahead and load it on the same day. Now, if you don't have good implant primary stability, you're not sure about the initial torque and everything, then you have to wait for the final processes, in which case you have to wait for minimum 2.5 to 3 months. Okay, so this is another case where we did a guided all on 4. So a guided all on 4 is always good over normal all on 4 is because you get to plan every single detail of the outcome of the case. Okay, there's another question. Again, doctors, please refrain from asking questions now. You can ask the questions later. It disturbs the flow of the presentation. Okay, so I'll take this last question. Please write them down and ask the questions later. We will have enough time to discuss about questions. So in mandibular, do we need bicortical engagement? How to achieve in anterior mandible? Yes, bicortical engagement is essential anywhere. It's not only in the mandible, it's not only in the maxilla. In the anterior mandible, you have to engage it to the lower cortex. You have to put it straight down to the lower cortex. Okay, so coming back to our presentation now, I'm going to show you a digitally planned case and guided implantology done. So why do I like guided implantology is because we get to plan every single detail of the case. If you see here, if you see here, I get to plan where my screw axis is coming out. In the processes, I know what is my AP spread. I know what angles I have to use. I know every single detail before even I place the implants. So which is very good for the outcome of the prostheses. Okay, so we are securing the upper guide now. We have already fabricated the guide, and now we are securing the upper guide with the help of anchor pins. Okay, the upper guide is secure. Now we are doing the drilling through the guide. This is a completely flapless procedure. So the drilling is being done through the guide. And that is the implant being placed through the guide. That is the drilling being done anteriorly and implant being placed. So this is a picture of this is a picture taken just after I remove the guide. This is how clean and nice the procedure is going to be without any much hassle for the patient. So this is the lower guide. We are securing it with guide pins. That is the anchor pins. And this is the osteotomy. This is the implant being placed in the lower arch. Now, after I do it, what I do, as I said, I use a bone mill to remove the bone around the implants. It's the same thing I'm doing over here. Since it is a flapless case, we don't know what is inside. So it is better always to use a bone mill to remove the small amount of bone which is around the implant, so that to place your multi-unit abutment. The use of bone mill in the lower, as you can see here. So this is a picture of after placing multi-unit abutments and healing caps. So as you can see, it is a very nice and clean procedure. It is very good for the patient as there is no extensive surgeries, and we can give immediate fixed permanent loading if we want to the patient. So this is the lower. And this is the final OPG of the case. Now, we had the patient's own denture. Now we wanted to carry out our denture conversion procedures. So what we do first is we place putty on the denture, and we kind of want to make an indentation of where the screw hole axis is coming out. Now we know where the screw hole axes are coming out. So we take a burr and we make holes in those screw hole axes first. That is the lower. Okay, now what we do, we place titanium cylinders on the multi-unit abutments, and then we take a rubber sheet and just cover up the entire arch, so that whenever we are doing our pickup procedures, the gingiva is protected from the heat cure acrylic. Sorry, the exothermic reaction of the cold cure acrylic. Okay, so now we mix the cold cure, load it into a syringe, we place the denture in position wherever the optimal position is, and then we fill the gap with the cold cure acrylic. Once it is done and we wait for sufficient amount of time, we remove the prosthesis. That is called the pickup. That is why it's called picking up of the prosthesis. Now we pick up the prosthesis and then we convert it into a denture, fixed denture. So we remove the flanges, we add more acrylic on it and making it a convex surface which touches the tissue, and then that is called the denture conversion. Okay, so these are converted dentures placed in the oral cavity on the very same day. Now, how we take our open tray impressions or our implant impressions is through a device called iCam 4D. So what we do is we place scan bodies on the top of the implants and capture the three-dimensional positioning of the implants. After the three-dimensional positioning of the implants is captured, we already have converted the prostheses. So we take the scan of the converted prostheses. So in one single day, we get the whole idea of the VD, vertical dimensions, jaw relations, and implant positions. So we have all the three in one sitting. Okay, so now that we have all the three information, we go ahead and mill a titanium bar. So this is a milled titanium bar. So we place it onto the patients, we try it on. After the trial is done, this is a monolithic PMMA suprastructure. So it's fixed with titanium bar and a monolithic suprastructure. So what are the advantages we get over here? The titanium bar is extremely rigid and it provides extremely good cross-arch stabilization. Monolithic PMMA offers good shock absorption, as well as it is very aesthetic. So after the prosthesis is placed, now you can see the prosthesis engages all the implants evenly. This is a very good passively fitting prosthesis. Okay, now we have another guided case where I did not do a fully guided procedure. This is a pilot drill guided procedure. So this is a case where I wanted to do zygoma. Actually, it's an ideal case for zygoma, but then the patient insisted on all-on-4 and he didn't even want a surgery. So we went ahead to do a guide for him. After we secured the guide like this, this is a pilot drill hole. That means only the pilot drill is being done here. After the 2 mm drill is done, I use a osteodensification burr and just widen the osteotomy. After that, I place my implants, and that is my multi-unit abutment placed. And this is all the 4 implants placed. This is the converted immediate denture, the patient's own prosthesis. We converted it and the patient goes home like this. And as I mentioned before, we do all of those digital impression procedures, and the patient gets a long-term prosthesis the very next day. In long-term intermediate prosthesis. This is the monolithic PMMA prosthesis. So it's very aesthetic, it's very clean and very neat. And the patient gets it the very next day. Okay, so now it's time for okay, so there's a question now. In the second case, the cortical is not engaged. So let's go back to see if that is true or not. If you can see over here, this is the cortical plate. Now it extends from here to here. It's not that I have to go all the way inside. And one more thing is, as I already told you, the tilt of an implant is not two-dimensional, it is three-dimensional. So I will, if I'm not engaging the upper cortex, I will be engaging the buccal cortex or the palatal cortex. Either which way I will engage another cortex. Okay, so now we go into examples of previous cases. So there's one example of this case who walked in like this, all the teeth were mobile. So this is a situation. It's a terminal case of extreme periodontitis, and all the teeth were in grade 2, grade 3 mobility. So we removed all the teeth. We placed all on 4 implants in this way. And these are immediately converted dentures on the same day. And this is how the patient has walked back home looking like this. And after 6 months, this is a mallow framework, upper and lower. And this is how the patient looks now. So this case is, we have a follow-up of about 4.5 years for this case now, and the bone is looking absolutely beautiful now. So this is another case where we had done all on 4 in the maxilla, and we had gone for 5 straight implants in the mandible. If you have bone, you go for 5 straight implants in the mandible. Again, so implants were placed, and monolithic PMMA long-term prosthesis is given to the patient. So that's how the patient has come in, and that's how the patient left our clinic. So another case where the patient had extreme loss of teeth and loss of bone as well as mobile teeth with a lot of infection. So we removed all the teeth, and we had given implants in this way. And we had done a mallow framework in the maxilla, and we had done a implant bar with PMMA suprastructure on the top. So this is how the patient had come in before. So that was the initial scenario, and now the patient looks like this. So it is extremely hygienic. She maintains it very well. You can see the extremely healthy gingiva. So that's how the patient had come before, and this is how she looks now. Another case where we wanted to, I mean, this is her name is Razia, and she had come, and her daughter had come and saying, my mother needs to be fixed. Her smile needs to be fixed. So we had removed the teeth. It is all obviously a terminal. So we had removed the teeth. We had done all on 4 for her, and we had given a mallow framework. That's how she had come in. And this is the final outcome with mallow framework. So that's how the patient had walked in, and this is how she ended up looking after the permanent prosthesis. So another case, so you can see the density of the bone is very, very less, and there is extreme periodontal infection to the remaining teeth. So we removed all the teeth, and then we placed our implants, all on 4 implants. And we had given her a long-term temporary prosthesis. So this was how the patient had come, and this is how she was looking after her prosthesis. Okay, so another case where she had walked in without any teeth in the upper jaw. So if you can see, the bone is extremely, I mean, the density is very, very less. It's extremely low density. I could literally take my periosteal elevator and puncture the bone inside. For this case, I remember very well. So we had to densify the bone and place the implants like this. So this was the prosthesis given to the patient. So this is another case where the patient walked in and he's a high level employee at a very famous MNC in Hyderabad, a IT company. But he told me that I don't look the part. Obviously, he doesn't look the part. So this is his oral condition. So we removed all the teeth. We went for all-on-4 implants. And this was his long-term temporary, and this was his mallow framework. That is a permanent framework. And now he looks the part. This is another case where we had rehabilitated the upper. The patient only wanted upper. She didn't want the lower, in spite of us telling that she needs lower, but she didn't want lower at all. So we had placed the implants. And this is the long-term temporary. Believe me, this patient, I think we had done this case 4 years ago. She's still on long-term temporary. She had not come back yet. She is saying she's very comfortable with the long-term temporary. So this is another patient. Very poor bone condition. We removed all the teeth. We had done all-on-4 upper and lower. So this is the scenario. This is the outcome after immediately after the this is a long-term temporary placed to the patient. Okay, so this is another case where we had removed the upper teeth. The patient wanted only rehabilitation of the upper teeth. So we removed the upper. We had done all-on-4. And this is the immediately converted prosthesis. Okay, Dr. Javed, I had seen your question. You had asked for implant system surgical guide protocol. As I said, I will answer all of your questions after the seminar. So this is the outcome after the denture converted. Okay, now we have come to the end of the webinar. I will be taking questions now. Let me finish the few slides that I have left. So this is Sarita Dental Clinic. This is the practice I work in. And this is our laboratory. This is the Crown Company. We have all the latest toys. We have the latest CAD/CAM equipment available in our laboratory. So we have a 5-axis wet milling CNC machine, and they do all of our prosthetic works you saw. And I have the privilege to work with a wonderful team of doctors. And we also conduct implant courses regularly. We do basic implantology, all-on-4, zygomatic implants, guided implantology, implant prosthetics, grafting in implantology. So anything to do in implantology, we have a course for it. You can enroll for any course you want based on the availability. Now, regarding all-on-4, we are doing an in detail all-on-4. Whatever you have heard till now is just an introductory all-on-4. We are doing an in detail all-on-4 webinar in which I will have a detailed discussion on all-on-4. You will also be getting a prosthetic module in that, and I will also be doing a live digital planning on Blue Sky Bio software. So I use Blue Sky Bio software to plan my cases. Sometimes I use it to create my guides also. Planning in any software is very, very essential before you go into a surgery, just to understand how the bone is and everything. So in the detailed all-on-4 webinar, which is coming maybe next week, our organizers will guide you on it. Maybe next week, Sunday, there will be a detailed discussion on all-on-4. There will be a prosthetic module on how to do the prostheses for all-on-4. And I will also be doing a digital planning live on Blue Sky Bio software. Okay. Thank you so much for listening patiently on a Sunday. I hope it was a very informative session. Now, let's take questions. Okay, I think I stopped over here. Okay, Dr. Javed is asking implant system. Which implant system? I think in the cases that you have seen, I have used Noris and Nobel. These two implant systems I have shown you of the cases. Some cases were of Alpha Bio. The guide protocol for complete denture. Dual scan. Yes, we have to we have to make a complete denture first. We have to do a double scan. And then with that double scan, we need to plan the case and fabricate the guide and then 3D print that guide. Okay. Okay, so there's one question from OnePlus. I don't know who is it. Okay, so in high IIT case, why no all on 6? So let us go to that case and see what is all the thing. Okay, so if you notice over here, if I wanted to do all on 6, I had to go for pterygoid implants over here. There is no other way I can do all on 6 in the maxilla. Now, if you're asking if in the mandible, why I went for all on 4, it is because if you have only all on 4 in the maxilla, there is no point in going beyond that in the mandible because there is no need for that over there. That is the reason why I stuck to all on 4. And now we are experimenting with all on 3 in the mandible. Mandible is a very, very strong bone and it can take only 3 implants. It's getting a full prosthesis with only 3 implants. It is good. So 4 implants is really, really good in the mandible. Okay, Dr. Vijay is asking how to identify the mental nerve. Mental nerve is identified by simple flap reflection. You have to reflect the flap until you see the mental nerve. Once you identify the mental nerve, you have to preserve it. Okay, Dr. Divya Agarwal is asking, are multi-unit and angled abutments the same? No, they are not. Multi-unit abutments are different and angled abutments are different. Multi-unit abutments are it has dual screw channel. So it has 2 screw channels for multi-unit abutments. One screw channel helps you place the abutment to the implant and another screw channel engages the prosthesis to the multi-unit abutment. Whereas an angled abutment has only one screw channel where it, it can tilt, your prosthesis can be tilted, but you can only do cement retained prosthesis. You cannot do a screw retained prosthesis in an angled abutment. Okay, so another question is how to prevent lingual artery perforation in anterior region in the mandible. I don't think you will need to, I mean, if you're doing a full thickness flap elevation in the mandible in the lingual side, you don't have to worry about lingual artery damage as long as your implants are inside the bone. So when your implants are within the bone, you don't have to worry about lingual artery. Okay, Dr. Amrita is asking acrylic or bar attached prostheses. I think that the question is a little bit vague, Dr. Amrita. Maybe you're trying to ask in the temporary, am I doing acrylic or bar attached? In the temporaries, it is either converted prostheses. The converted prostheses is a short-term prosthesis, which I use only for a few days until I do a long-term temporary prosthesis. The long-term temporary prosthesis can have a bar inside, or it can be a monolithic PMMA also. Anything is fine. Okay. So Dr. Sri Lalita is asking, long-term temporary prostheses, what is given? The material and the prostheses. I think I have answered this question in the previous one. Long-term temporaries, I give a bar inside. If for some cases, I give a bar inside and a suprastructure on the top of it with acrylic. For other cases, for some cases, I give only PMMA, monolithic PMMA. And sometimes if the converted denture is really good, we don't even give long-term temporaries. Dr. Vijay is asking whether to go for bone guide or soft tissue guide. It's a very, we can do a separate webinar on that topic. It's a very deep topic. Soft tissue guides are limited in many ways. They are not as accurate as a bone guide. So, but soft tissue guides have many advantages over bone guides. Soft tissue guides enable for a very, a least invasive procedure, least invasive surgical procedure. But then you have to be very careful with a soft tissue guide. Whereas bone guides are more accurate. Bone guides are more, you get to see what is happening while it is happening. So it is more easier for you to do that case. But there are disadvantages associated with bone guides. One, it is difficult to make a bone guide. It is a lot more time consuming. You need to elevate a lot more when you're using, you need to elevate a lot more soft tissue when you're using a bone guide. So there are advantages and disadvantages. I have done both. I like both of them. So we have to, and in cases where you need to do bone reduction, or in cases where especially in bone reduction cases, you cannot do a soft tissue guide. You have to go for a bone guide. Okay, so Dr. Divya Agarwal is asking, in basal implants also, you tend to engage the bicortical plate. So what is the difference? It's a very good question, Dr. Divya. Contrary to the popular belief, the basal implants are not bicortical implants. They are cortical implants. So the basal implants engage only the superior cortex and do not engage the occlusal cortex. If you see, the implant is narrower at the occlusal side and broader at the other cortex, the basal cortex. Okay, so because of which it engages only the basal cortex, it doesn't engage the other cortex. So because of which the bone around the occlusion is not stimulated, and it allows the implant to move slightly. Okay, because of which it has bone loss even after placing the implants. After the placing the implants, you're supposed to retain the bone level, but because of this, there is bone loss. Okay. So we have Dr. Dinesh. His question is, why should we start with tilted implants first in all-on-4? That's more of a preference. You can do either way. I like to start with the tilted implants because it sets me, that is the posterior most I can go. So I can go anterior most in anterior implants, and that is the most difficult part to do. So I like to do the difficult part first. So I go for the tilted implants first. You can go the other way also. The second part of the question is, when we do bone reduction, how can we adjust guides in such cases? So when we do bone reduction, we have bone reduction guides. So these guides help us to do bone reduction. I have done many of those cases. So maybe in the next webinar, in the detailed all-on-4, I will show you that case also. So I'm sorry. So both the bone reduction guides are separate. Okay. So the next question, sir, in the case of immediate loading, which is the best, sir, all-on-4 or corticobasal implant? I mean, it's asking, it's apples and oranges over here. It's different for different modalities. Corticobasal is a different modality of implantology, and all-on-4 is a different philosophy of implantology. So there is no comparison over here really as to which is better. There's another question. How is this better than bicortical basal implants? This is better because we get to do screw retained prostheses. In basal implants, we can give only cement retained prostheses. And in basal implants, we have to give more implants to do the same job. Now we can do with just 4 implants. But now we have basal implants with multi-unit abutments. I use those implants as well. My problem with basal implants is the prostheses. We can only do cement retained prostheses, and we cannot do a screw retained prostheses in basal implants. And the number of implants, what you can do with 4 implants here, you need 10 implants in basal implants. Okay, so Dr. Prashant is asking, sir, does MalloGuide support all the systems in the market? Yeah, MalloGuide is an open thing. It doesn't depend on any system. It just is a markings are given and you can use it to anything you want. Okay, Dr. Dinesh, how do you do case selection in diabetics? Post-operative instructions is specific to them. Now, in diabetics, it is important to take the HbA1c levels of the patient. Anything at 7 or below 7 is good. We can go ahead to do immediate loading. Anything from 7 to 9 is dicey when it comes to immediate loading. Anything above 9, no immediate loading. So you cannot do immediate loading above 9. Okay, so you ask the patient to reduce it, and then you go ahead for the this thing. And the specific instructions you have to, there are no specific instructions other than reducing the sugar level. You have to be on extremely soft diet. Okay, Dr. Divya Agarwal is asking, can you explain in brief again the pickup cold cure impression procedure? Now, we can, but we are running out of time. Maybe in the next webinar, there is a detailed prosthetic session done by my prosthodontist. You can ask that to her. So another question, most of the clinicians do freehand. They say guided might be wrong. Yeah, again, that's a different webinar altogether. There are a lot of things that can go wrong with the guides, but if you use the guided technology properly, and if you understand the guided technology properly, it's a very, very valuable tool. It can take your implant processes. I mean, it can take your implant surgery accuracy multi-fold. So after I have understood, even I used to be under the impression that guides are not accurate, but after I've understood the whole guided philosophy, and I started planning my own cases, I started making my own guides. I understood that guided implantology is much more better than freehand implantology. Like what you can do with guided, you can never achieve with freehand implantology. Okay, Dr. Vijay is asking, if not giving temporary processes, we leave multi-unit abutments freely. Yeah, we can leave multi-unit abutments freely as long as there are no forces falling on the multi-unit abutments. Just check if the opposing teeth are touching the multi-unit abutments. If they are, then it is not advisable, because then the implant is isolated and it is taking all the forces. It might fail. If there is no forces falling on the multi-unit abutment, you can leave the multi-unit abutments in place. Dr. Dinesh is asking how much torque is given for abutments in all-on-4. That vary with, yes, it varies with implant system. Every implant system has a torque specification. You have to know that and then do the same thing. Another question, charging for guide for full arch. As in, are you asking what is the cost for guide for full arch? It varies. It depends upon different laboratories. You should ask the guide provider in your area or your place, whatever they ask for. How we should start? Dr. Manan is asking, how should we start? Freehand or guided? Yeah, it's a very good question. I would say you start freehand. Guides will be a little bit more cumbersome for you to start off. You start with freehand. Once you understand the shortcomings of freehand, you yourself will gravitate towards guided. Guided is for the experienced people. So Dr. Amrita is asking, in maxilla, 4 implants are enough, or should I go for 5? Yeah, 4 implants are enough. The latest ITI consensus says that 4 implants are enough in maxilla for immediate loading. If you have the bone for 5, place 5. Dr. Prashant is asking, sir, in upcoming detailed all-on-4 webinar, will you be showing us both surgical and prosthetic? Yes, I will be showing both surgical and prosthetic protocol. My prosthodontist will be taking the prosthetic protocol. So another question, minimum length of implant for bicortical anchorage in mandible for immediate loading. There is no such known as minimum length. It is about the available bone, and for individual cases, you have to go for that much of the length of the implant. So I use implants of 18 millimeters very frequent. All of my cases are 18 millimeter length implants. Very few companies have these implants. Norris Implant Company has it. Nobel has it. So that is the reason why I stick to these companies, because they have a very long implants. So Dr. Dinesh is asking, Dr. Dinesh is asking, so even if the patient is having about 10 HbA1c, can we place the implants? Yes. So you can place the implants even if see, you just think about this. If the patient is diabetic and the patient underwent a trauma and he broke his leg, won't he undergo the surgery for the fixing his leg? He will, right? It is just that they have to undergo a strict diabetic regimen for about 2 weeks, bring the HbA1c at least by 1 point or anything like that, or RBS level has to come down to a favorable level, and then proceed your surgery. But the surgery has to be extremely sterile procedure, which I think any surgery should be a sterile procedure. Any full mouth implant case you're doing has to be an extremely sterile environment in a minor OT conditions. So I don't think that should be a deciding factor. About 10 also, you can proceed placing an implant. Okay, I think we have a last question here. Dr. Vijay is asking, is it necessary to put healing abutments on multi-units when not placing temporary? Yeah, that's when not placing temporaries, it is definitely better to place healing abutments on multi-units because you don't want the soft tissue cover on the top of the multi-units. It is just a cumbersome thing for the prosthodontist to come and deal with it later. So otherwise you'll have to use laser and cut down the, take out this thing. So I think, guys, the time is up. It is already 7:30. Now, if there are any questions, I will take them, but the participants are free to leave this thing. Thank you so much, guys. Thank you for waiting. I mean, going through all of the 1.5 hours. I hope it was a very informative session, and let us know if you want to do further webinars like this. And hope to see you on the next detailed all-on-4 webinar. What I have shown you is the extreme surface level of all-on-4. All right, guys. So I have few more questions. Let me take those few questions, and if anyone wants to leave, they can leave. Okay, so another question: if placing implant of 4x11 for all-on-6 in mandible can load immediate. Okay, so can we load immediately? Now, as I already discussed before, it is not about the length of the implant we are placing. It is about whether we have sufficient primary stability, one, and whether we have bicortical anchorage. Now, if your implant is resting inside the trabecular bone and the apex of the implant is not attached to the cortical plate, now just imagine the implant is in the trabecular bone, and now you have loaded immediately. Now the implant undergoes remodeling. During the remodeling phase, in 2 weeks, I said the primary stability dips. In this remodeling phase, the implant is at its weakest. Now, when you have already immediately loaded, there are forces falling on these implants. Now, how are you going to escape these forces? Now, whether they are going to fail or not is secondary. There is always a chance of failure in this scenario, but it is not like compulsorily they will fail. Definitely, there are situations where you can get away with it. But if you want to do immediate loading, it is always better to do pick up the longest possible implant and engage the cortical plate. Okay, Dr. Dinesh is asking occlusal scheme in all-on-4. As I briefly said, there are the full scope of prosthetic rehabilitation will be done in the detailed all-on-4. Please attend that session. You will have a detailed explanation about this one. Okay, Dr. Basu is asking, what will be the minimum length of implants for bicortical anchorage? As I previously mentioned, there is no minimum length. It is the maximum. It is the utilization of maximum bone available. So whatever bone is there, you need to be able to engage it. But if your question is, okay, if the bone itself is very small, that I'm using a 10mm implant or a 13mm implant length, I wouldn't do an all-on-4 and I wouldn't bank on it. I would go for zygomatic implants in that place. Okay, for me, if I have to say what is the minimum length, I would say if you are able to place minimum 16mm or 18mm implant in the posterior most regions and in anterior regions, then I would say that's a very good length. Okay, in the posterior, another question, in the posterior mandible, how we come to know about second cortical anchorage? If you're even in the posterior mandible, if you're angulating the implant anteriorly, you will get to know while you're placing the drill will have a stop and you will feel the other cortex while placing the implant. And if you're doing a guided procedure, you will definitely know the angulation and and the place where you are getting to engage the other cortex. So that should not be a problem. Okay, Dr. Dinesh says, thank you so much for the patient explanation. Have a productive weekend. Thank you, Dr. Dinesh. You have a productive weekend too. Okay, guys, if there are any questions, you can shoot, but I think it is time up now. Thank you so much for the patient listening. And I will see you in the next week, hopefully. If you have any questions after this, please use the WhatsApp group. I might take few questions in the WhatsApp group. Okay, have a great evening, guys. Thank you so much.